Hi everyone, and those online. I think there's a few as well. Thanks very much for having me. As I've said already, my name's Louis. I'm based here, Associate Professor, and at Great Ormond Street, where I work in paediatric infectious diseases. So I'm going to talk about three concepts today, two of which I've just published on with others in my group. So there's a lot of data kind of supporting it and things, and then one completely new about which I don't know a great deal, but I think it's quite exciting. So I'll run it past you and see what you think. Okay, so three concepts, right? And I think to kind of give you perspective, in a TB group or group interested in TB as we are here, it's quite nice to look at this graphic here from Paulson in 2013, who wrote a graphic review in Nature. About the last 200 years of TB. And I think this graphic here really describes the havoc and destruction that TB has wrought on the global population, with responsible for 1 billion deaths, which kind of pales in comparison to literally all other infectious diseases, which form the other circles in this graphic. And you could add them all up and they still wouldn't combine to the number of deaths that TB had contributed to over that 200 years. And I've actually sneakily adapted this graphic at the bottom here to add in SARS-CoV-2. You can see in the deaths, the 6-point-something million deaths responsible, from this virus. And so it really puts the whole thing in perspective, I think. And I very much suspect that we'll go back to TB being the single most deadly global pathogen in the next few years, and COVID will become part of the circulating. At least I hope so, because we're all pretty fed up with COVID and keen to get back to what we know best in TB. So anyway, I like this graphic and I think it's worth looking at. So into the first concept for the talk. And I've been obsessed basically with the notion of transmission in TB since I started in research in about 2008. And I really like the idea of the super spreader and trying to find out who that super spreader is. Is it honey? And what are his characteristics? Is it his kind of hypersocial skills? Is it the bug that he's got? Is it the small house he lives in? What is it that leads him to be the super spreader in this group, and can we pick him out, and can we then lock him in a room for 6 months and prevent him from doing, those sorts of things I find really interesting and intriguing. And I guess this is what has driven my research interest over the last decade or so. And so what is this important is the first question. Do we need to even know who transmits to who? And I would argue that it definitely is, because if you go to a nursery school outbreak, and I've been involved in a few of these outbreaks going in kind of with PHE and things like that to try and pacify the nursery school teachers and calm everyone down when the teacher and various pupils and things have been infected. You need to know where the TB is coming from, who was the source case, who brought it in and how, and without that data, you're literally clueless. You have no idea where it came from. And I should say that this applies both to TB and to all other respiratory infectious diseases. So this concept is not just limited to TB. I think it's really crucial to try and pin down the chain of infection, how infections go spread amongst us in the community. So yes, I think it is very important. If you can pin down transmission links, then it allows you to get back to the origin of the infection. So the key, recent one to highlight is whether the COVID pandemic originated from laboratory or from the wet market. Still unclear. And if you can pin down these links of transmission better, then you can find out where, have a better idea where infections emerged from. And so so to sort of simplify this hypothesis, the first one is that not all of these aerosols that you see coughed from one person to the other are the same. And so when I cover poor Eloise in a big cloud of snot and aerosols, transmitting my COVID or whatever it is, I would argue that all of those little dots you see there are subtly different genetically, okay? And actually there's a huge amount of within sample or within cloud variation in terms of the genetics. And so I guess in sort of scientific terms, harnessing that within sample variability will, I think, improve our ability to determine who infected who. And currently, you can see what you get is this person on the left, you get a genetic code here, which is very often identical to the person on the right, even with whole genome sequencing. So it means you have absolutely no idea who came first or who came second in your in your transmission chain, and all you've got to go on is a bit of epidemiological data, which can be quite unreliable, you know, and symptom onset dates as well, which is not very helpful sometimes. Okay, so if we can find a means of teasing that all out, then that's great. And so this is what we've got some recent quite nice data on, and this comes from the CoStar study that I led at GOSH, where we recruited 2,800 members of the hospital fairly rapidly in the first wave of COVID to study their transmission amongst them, and also look at their immunity. Okay, and on the left of the graphic here, you can see what is done conventionally with whole genome sequencing, where basically, I don't have a laser pointer, but up here you can see if there's variation at any given site, you know, what is done conventionally is, oh, you forget about it, just, you know, let's just call it the major variant. It's a G. This is important, this is unimportant, this little T there, let's just call it a G, because that's broadly what's going on. But actually what I would argue is actually that variation is really important, and you need to actually explicitly code it differently. Okay, and if you do that, then suddenly you get much greater definition from your transmission chains. And we've shown in this graph on the far side there that you can see this minor variation appearing in the first case, and then at the same frequency in the second case. So it's stable between cases, right? And so this is this new concept of infectious diseases transmission that we are proposing, that rather than just mutating from G's to A's and T's and C's, that actually there's a kind of an intermediate step here, where C's go to getting a few G's and then predominantly G's, and then they switch over completely. So it's kind of grey scale of mutation from one state to another, and that actually buys you a lot more definition. And when you do that, and what was quite interesting is when this is the finance department of GOSH, and when the when the pandemic hit, we formed gold, silver, and bronze command chains and things. And basically, the gold command all went into the special gold room and started talking about very important things in their small, you know, in the small room. And of course, what we didn't know at that stage is that the virus was in and amongst us and had been for months. And so immediately, the entire top brass of the hospital got taken out within a few weeks. You know, well-intentioned as it was, in retrospect, it's obviously the wrong thing to do, right? But anyway, when we sequenced all of the finance department strains, you know, you can see this is what you get with conventional sequencing, essentially a flat line of randomly labeled dots with absolutely no idea who came first or who came second. And then when you use this inclusion of minor variants, encoding of minor variants, you see exactly who comes first and who comes second and who infected who. And so you start to really unravel the transmission chain. And similarly, this is when you employ this really nice software by Heavy Diddler called Transphilo to the outbreak. You can see the conventional sequencing, you've got absolutely nothing. And then in another outbreak here, you get a lot of, you know, who came first, who came second. And this nice software, Javier's, who's lovely to work with, if any of you guys have had the pleasure, but you get an actual likelihood of who transmitted to who from this software as well. So you really start to be able to pin down precisely who gave it to who. And what I want to do is take this to the large population level into tuberculosis in Lima to see if we can find who those, you know, who those super spreaders were in the population who are responsible for all of this. And to see if we can improve the sensitivity of detecting the directionality of transmission. And yeah, and I should say that there were multiple small outbreaks in this hospital amongst the staff, and this is just 11 of those outbreaks. And in blue, you can see where we employed this new technique. We got temporal signal, that is to say who came first, who came second, who came third. And in red, our technique was rubbish and actually failed and gave us false information. And then these two ones in grey didn't give us any added information. So I should say all of these boxes for different outbreaks in which the conventional approach gave us no information at all. So I guess we're gaining something out of where there was previously nothing here in 7 out of 11 outbreaks. So hopefully that's a kind of step forward and something that should, I think, be useful in TB in a kind of hospital or household setting, or even in the community. Right, so that's the first concept. The second concept I wanted to discuss is something, again, I'm really interested in. Hopefully it's helpful. And this is based around the notion that not all pathogens are the same, and that some pathogens have an inherent predisposition to acquire drug resistance in the future. So the idea here is if you come to my clinic or anyone's TB clinic and you have a sensitive organism, I can tell you actually it's sensitive, but it has a pretty high risk of going on to get resistance in the future. So I'm going to slightly expand your therapy to cover that risk. Or the inverse of that would be you come to my clinic and actually I say, I look at it, you've got a sensitive organism and we know that these ones almost never become resistant. Therefore, we can cut your treatment course down for a bit and you'll still be fine. Do you see what I mean? Well, what I'm getting at. So the question here is, are all susceptible organisms the same, right? And I would argue that just like we have variation in anything in life, also, so some susceptible organisms have a much higher propensity to acquire resistance in the future, right? And we've been able to look at this statistically by going back in time through the phylogeny. So when you create a phylogenetic tree, essentially it just groups all of your genomes by their genomic proximity, and it gives you their ancestral states as well. So this is like the ancestor of these two, and it will also give you your ancestral genome. And so it allows you to go back in time to your different ancestors, and we use like a survival analysis framework. So this ancestor occurred at a certain time, and it went on to this progeny or subsequent node. And with that is an associated time to event. So what we did was a kind of survival analysis in this framework. And you can see here, absolutely nothing happened. It was just another susceptible organism. But in the red, in that T3 one, a resistance event happened. And so we have a kind of a timeline along which a resistant event occurred. And so just like in any survival analysis, like when the event is cancer or whatever, or death or mortality, similarly within a phylogenetic framework, you can do this survival analysis. And we applied this to TB, both in Russia and in Peru. And there's I think, around 3,000 samples from Peru and 1,500 samples or so from Russia. And what we found was quite stark, was that actually the two major lineages in TB differed dramatically in terms of their propensity to acquire resistance in the future. So you can see in Lima, the lineage 2, which is one of the largest global lineages, mainly based in Asia, acquired resistance at 3.5 times the rate of lineage 4. And when we applied the same analysis to an independent Russia data set, lineage 2 acquired resistance at 5 times the rate of lineage 4. Okay, so I would argue that this data suggests, or these data suggest, that it's a completely different organism, and should arguably, if we can demonstrate this in clinical trials or prospective clinical cohorts, should be dealt with differently. And then similarly, we looked at the scenario in which strains had lost one drug. So, when you see a patient with isoniazid monoresistant, and we tend to give them a slightly different regime to the usual regime, what is the risk of then losing the second drug or becoming multi-drug resistant, having lost one drug already? And again, this was pretty worrying. So in Peru, we found that the hazards of developing multi-drug resistant from isoniazid monoresistant was 15 times that compared to control. And in Russia, it was 40 times that compared to control. So this is particularly worrying in the context of GeneXpert, which is well, I'm not sure actually if it is the most widely used molecular test globally, but it's certainly very widely used, and until recently has only has been unable to accommodate the INH isoniazid monoresistant component. And so many people have been diagnosed with GeneXpert globally without being diagnosed with isoniazid monoresistance. There's plenty of people who have been missed with isoniazid monoresistance, and these hazards of developing MDR, I think, are quite concerning, and I wonder whether that's going to lead to a bit of a wave of multi-drug resistance in the future. And not just at the drug level, but also down at the nucleotide level, we noticed a deletion in LPPP, which conferred an eightfold increased hazard of acquiring resistance in the future. And this could lead to potentially to a diagnostic test in which you can identify these patients who have this mutation and potentially treat them differently. So what I'd argue here is what's needed is to follow patients with these mutations up prospectively to see how rapidly they acquire resistance or not, and see if this is clinically meaningful over the timescales that we are all used to, or whether this works on a kind of TB timescale over 40 years or something like that, which is kind of beyond us all. I'm not sure which of those is true, but it's certainly interesting to try and find out. And then I'll just finish by talking about this third concept, which I'm keen to run past you. And this is moving into now host transcriptomics and what many, and including myself, regard as one of the most important questions in TB research. And I know this is a kind of question that's close to your minds as well. We all are aware that 25% of the globe, according to the London School Who-Binds study modelling, are supposed to be infected with TB. But are we able to predict whether those individuals who are latently infected with TB go on to get disease? And if we can, then can we kind of target them in some way or other with treatment? And that's kind of the main reason why I think TB will be around and with us for beyond my career and for many more years. And so what I'm interested here is the notion of something called RNA trajectory analysis, where rather than getting one RNA sampled in time, you get multiple RNAs sampled over their course of treatment. And actually, this is just a nice graphic, weirdly, of the differentiation of olfactory cells. And you can see that along their path to becoming different types of olfactory cells. I don't know anything about the olfactory cellular setup, but you can see along that path, they start to diversify and change into different states. And I wonder whether this technique could be applied to TB patients, latent TB patients, and help us to predict their trajectory towards TB disease or not. So it's something I'm keen to do. And I'm also keen to try and understand how the pathogen influences the host transcriptomic response. So that's about it, and grateful for any questions that you may have on this. There's obviously lots of people that have been involved in analysing that data and putting that together, particularly Bob Gilman there with our silly hats on in his farm in Maryland, and Arturo Torres here, who's working on the train and is one of my PhD students at the moment. Thank you very much.
Louis, what a great really, talk for hours about that. There's so many questions. Questions?
Make them as horrible as you like. I really, honestly.
I really enjoyed the talk, and there's lots of different things I could pick up. And one right at the beginning, I was just thinking about the super spreaders and all the evidence is coming out from Leicester about people using masks to show that actually TB is being spread by people breathing out rather than when we traditionally assume it's going to be coughing. It's evidence that it's not that, it's just there are people who are just naturally breathing TB out, whether that's something that you've thought about.
It is something that I've thought about, and there are these new, the Kevin Fennelly cough monitor that you'll be well aware of, system of kind of entraining air into kind of microfluidics and culturing on a plate and things like that is very interesting. And there's also new techniques as well of air sampling that I'll be quite keen to implement in household settings. And let's say we find a super spreader, then maybe we can, we identified them earlier, and maybe we could employ that in households to sort of see if there's evidence of more TB in the air in those settings.
Just quickly follow up on that, because one of the things in 2 years of massive COVID research that we have heard about is lots of research on aerosols and super spreaders, and I just wonder whether you've learnt, what has been learnt from that?
Yeah, so something I was really amazed by in COVID. I don't know if you were as well, but was the kind of dogmatic positioning that many people had on mask wearing at the outset. Like some seriously informed and quite high-powered individuals. I don't engage in Twitter at all actually, but they would, I kind of would snoop a bit on Twitter and see what they're up to. And they would be absolutely vehemently against the wearing of masks in COVID. And I just thought it was very hard to be vehemently against something when there was no evidence one way or the other. And the other thing is just because there is no evidence doesn't mean to say that we shouldn't do something that's kind of commonsensical, right? I wouldn't put my hand in a blender. I don't need evidence to show that that's a bad thing. It's just obvious. So I would, was kind of arguing at the outset that why don't we just put a mask on, because it's not that hard to do, and maybe some of the viruses won't get through. It's not going to be perfect, but it might do some good. So I don't know if that answers your question nearly entirely, but I was a bit shocked at the kind of dogmatic positioning of many members of the quite powerful commentators on this, and how you can then sort of proselytize about that to your thousands of followers. I found a bit disturbing. Anyway, we're all wearing masks, aren't we, eventually? So, and I'm quite pleased to see them go, but there was no problem to wear them at the outset.
Louis, a question for you. And sorry, Conor, you can ask a question.
I was just issuing my notes.
Okay.
I'll get you later for a question.
I think that's been recorded. The question, you were showing some amazing data about how there may be lineages and therefore people who are infected by that who are much more likely to go on and develop resistance. And so how do you prevent that? Do you give people more drug? Do you select the drugs in a different way, or is it all about adherence?
Well, that's it. I have absolutely no idea. So what I'd argue is that we should take our data that we've got from the phylogeny into the real clinical setting and see, we know from the outset, if we get your genome back in a day, which we can now do pretty quickly, and if we once you get the culture, you should be able to turn around the genome quickly. If we can then get to that patient and say, well, we're going to follow you, what happens on your pathway, and two things can happen. Either you rapidly develop resistance over a period of a year or something clinically meaningful, or 2 years, and then we can argue, yeah, clearly we need to intervene and treat you differently. Or it may be that actually we don't see a signal, and this happens over 20 years or 30 years. I mean, I would argue that it definitely happens because we can see it happening there in the data. I mean, those hazards are insane, to be honest. I mean, in independent data sets, they're massive hazards. Whether you see that in the clinic setting or not, I don't know. So that's what I would argue we need to check that, because maybe we do need to treat them differently. And maybe the inverse is true. We can treat some of them with a few months. I sat at the back. Here we go. That's okay.
I'm a little bit annoyed by your data on transmission.
Yeah.
Because I've spent ages telling people the reason why Beijing transmits so quickly is because it comes from Beijing, and there's, in all the years we hadn't found any specific reason why Beijing strain should be more transmissible.
That was all COVID.
Yeah.
So that transmission stuff was on SARS. So you're fine.
Oh, okay.
Don't worry about that.
So
I haven't proven anything about Beijing transmissibility. So don't worry, you can keep saying that.
So that's great. That's a great relief. It shows why you shouldn't come to a meeting.
Yeah, it's fine. I can go back and show you the slide.
Okay, but then you should. So going back to what Mark was asking about, which is the drug resistance thing. So what's the gene? The drug resistance data. You highlighted LPP or something?
Oh yeah.
So what's that gene?
So it's a lipopolysaccharide, LPPP, on the kind of outer surface of TB that may be engaging in the kind of immune interface of it, but it's this sort of spectrum. I don't know much about it.
So I guess I mean, so it's sort of most like a non-specific sort of thing, isn't it? But hard to pin down. So what I was trying to work out is how we would move from looking at that as a sort of non-specific surface molecule associated possibly with cell wall, and how we would use that in terms of a diagnostic pathway, and how we would use. I guess what you're saying is we need to explore it.
Absolutely.
But I wonder whether, and you've got some other molecules up there. So so I'm really just expressing sort of how do we think about that? Do we start thinking about, when we talk about biomarkers for understanding outcome in TB, people hang their hats on one or two specific markers. I guess the thing to do with this would be to start looking at it in the combination with different markers and start thinking about sort of composite biomarkers that we can use to identify outcome. Do you think, is it realistic to think that we might get to a situation where, as well as doing a gene expert test so we get Cepheid to put into their gene expert, not only MDR, not only rifampicin and isoniazid, but a couple of biomarkers which we say, actually, this patient is going to be, is likely to go to more severe disease, and this one's not. You think that's realistic? I don't know.
I don't know.
I'd like to
I honestly, I mean, the hazards of some of these things. I mean, I would argue that looking at the hazards of Beijing here, in Russia, 5 times more likely to get resistance than. I would argue that your Cepheid cartridge should contain Beijing, and that you should maybe see them more than monthly or something like that. Or you might not augment your treatment necessarily, but you might keep a closer eye on these people. And you might be careful about discharging them from hospital. You might adapt your infection control procedures. And just to answer the other bit of your question, which was, you can actually pin these things down by these Luria-Delbruck fluctuation assays that you'll be aware of, where you can take strains of interest against a control strain, and you can grow them from a tiny amount up to a vast quantity to work out how many mutants occurred over a given period of time in this group compared to this group. So you can study these things in the lab, albeit that is not including that kind of immune interface with the macrophage, where many of these dynamics may play out.
Yeah, I mean, those kind of things. So the other thing which is interesting is over the last few months, we've been involved in conversations around this big TB clinical trial. And one of the things that means is being really interested in our TB clinical trials, rather than taking any TB infections, we focus on those severe disease. And it might be interesting to think about markers. If we had some confidence in these markers of outcome, and using those to stratify those patients we were going to put into the TB trials to increase the granularity of the trial test.
Yeah.
So that we might not get to a diagnostic test, we might get to a point where we can use it as a biomarker to help us stratify the patients and increase the success, the granularity of the test.
Yeah.
So that might be a useful way of using it. I'll give this back to Mark now.
Thanks.
Just to come back to Tim and why Beijing might be different. I mean, the only major thing that I know about Beijing that might be different is that DOS-R is constitutive, and the fact that you have a major dormancy type of response that is constitutive in the strain might well lead to, it might, for instance, mean that it's more likely to cause drug resistance, but it might be less transmissible, for example.
We showed actually separately that its mutation rate is significantly different than lineage 4, really significantly. I've got other data, but it's as stark as this, and we're not the only group to have shown this, but we're the first to have shown it phylogenetically like this in 2 different data sets. So I'm not convinced as much, but I'm pretty convinced that the mutation rate is greater in Beijing, and that the propensity for resistance is greater.
And it might obviously differ in people compared to in vitro, which is another thing.
And of course, the UK actually does, well, almost the UK, England and Wales does whole genome sequencing routinely on TB strains and NTM. But for TB, we rarely get an indication actually of the lineage because it's buried. And maybe that's the first thing we should do, is say to the clinicians, this is lineage 4, this is lineage, and this is lineage 2. Be concerned, think, try harder, because actually we know if that information doesn't go to the TB nurses, doesn't go to the TB services, but there's probably an experiment, there's probably a natural experiment there just in UK HSA data. Louis, I said it was going to be a good talk. I was wrong. It was a bloody brilliant talk. Thank you so much indeed.